ECG or electrocardiogram is the graphical representation of the electrical activity of the heart. The heart consists of SA node, which is responsible for generating this electrical activity, and AV node, bundle of its branches, and then Purkinje fibers, which is responsible for the conduction of this impulse. When the SA node fires the signal, it spreads to the atria and the atrial mass is depolarized. This leads to the generation of upward deflection or P wave in the ECG. Then this signal reaches the AV node. The AV node momentarily delays this impulse and then it spreads to the ventricles, which are depolarizing. During the time when the ventricles are depolarizing, the atria are undergoing repolarization, and that is the reason why QRS is superimposed on the atrial repolarization wave within the ECG. After the ventricles depolarize, they undergo repolarization, and then the entire heart loses its electrical activity till the next signal is fired by the SA node. These phases of the heart are shown by the following PQRS and T wave. The PR segment shows AV nodal delay. An ECG consists of three parts: waves, intervals, and segments. The difference between an interval and a segment is that interval includes wave within it, whereas segments do not. So there is a PR interval and a PQ or a PR segment. The PR segment is present between the P and QRS complex. The PR interval is present from the start of P wave to the start of Q wave. An ST segment that lies between the S and T waves, and a very long segment that includes the entire QRS within itself as well as the T wave known as QT interval. Now let's discuss each part one by one. The P wave, as we said, shows the atrial depolarization. If this P wave is absent, this means that the atria are either not depolarizing or their depolarization is ineffective. On the other hand, if this P wave looks different, either it is tall, known as P pulmonale, this means that the right atrium has been dilated. If this P wave is bifid, that shows that the left atrium is dilated. The next thing we encounter in ECG is the PR interval. PR interval comprises the duration from the onset of atrial depolarization till the onset of ventricular depolarization, and its normal duration is 0.12 seconds or 3 small boxes. If this PR interval is prolonged, this means that the impulse that reaches from the atria to the ventricles is delayed or is slower, and this occurs due to conduction block. If it is shorter, it means that there is an accessory pathway that allows a faster conduction from atria to the ventricles. This happens in Wolff-Parkinson-White syndrome, in which an accessory pathway connects the atria to the ventricles and the AV node is bypassed. The AV node causes the main delay, so it's bypassed here. The conduction block can occur at any point from AV node till the Purkinje fiber, and on that basis it has different types which will be discussed in later videos. Whereas the Wolff-Parkinson-White syndrome has a accessory pathway or a shortcut route that connects the SA node to the next is a QRS complex that comprises of Q, R and S waves. This QRS complex shows ventricular depolarization. It lasts for 0.12 second or 3 small boxes. When there is abnormality, it causes longer duration of the QRS complex, and this abnormality is known as ventricular conduction problem, in which the ventricles are depolarizing slowly. This is either due to right bundle branch block or left bundle branch block. The AV node is connected to the bundle of His, which branches into right and left branches of the conduction system. If there is block in these branches, it gives rise to RBB or LBB. In this case, the ventricles depolarize slowly, and so the QRS is of longer duration or broad. The QRS complex can be abnormal, showing higher amplitude than normal or lower amplitude. A higher amplitude indicates that more voltage is being generated by the ventricles, which can be either due to ventricular hypertrophy, in which there are more number of cells within the ventricles and so more voltage is generated, or in hypernatremia, when there is more sodium ion outside the ventricle muscle cell. More sodium gets inside the cell during action potential, and so more voltage is being generated. If the QRS complexes are of low amplitude, they show that low voltage is recorded. This is either in obesity or in a sarca, which is generalized body swelling. In both these cases, there is either a adipose tissue or fluid that blocks the action the voltages um, from reaching the precordium. Imagine an ECG probe electrode on the precordium and the adipose tissue between heart and the probe. And therefore, in a thin lean person, the QRS complex will be of higher amplitude. The ST segment is the next important thing in ECG. ST segment can be abnormal in two ways. Either it is elevated, known as ST elevation, or it is depressed. In both cases, the ST segment is always compared with the TP segment, which is always on the baseline. The ST elevation looks like this, and ST depression looks somewhat like this. The ST elevation occurs in STEMI, ST elevation myocardial infarction, and it is also seen in pericarditis, whereas the ST depression occurs in NSTEMI, non-ST elevation myocardial infarction, and the unstable angina. These will be discussed later in detail. Next is a T wave. The T wave on ECG shows ventricular repolarization. The T wave is abnormal in two ways. Either they appear really tall, which occurs in hyperkalemia and the hyperacute or the very initial phase of myocardial infarction. After this tall T wave in myocardial infarction, they undergo inversion. So inverted T waves are seen in ST elevation myocardial infarction as well as hypokalemia. The mechanism of these abnormality will be discussed in later videos. Then there is QT interval. The QT interval comprises of the entire QRS complex, the QT segment as well as the T wave. The QRS complex shows ventricular depolarization, whereas the T wave shows ventricular repolarization. So the QT interval comprises and includes both of them. The QT interval is normally 0.35 to 0.45 seconds of duration, If it is less or shorter, it is abnormal, and if it is longer, that's abnormal too. Shorter QT interval occur in hypercalcemia, whereas longer in hypocalcemia. Antiarrhythmic drugs, and genetically when there are mutations in the sodium and potassium channels of the ventricular muscle cell. In hypercalcemia, there are more calcium ions outside the ventricle muscle cell, and so they can quickly enter the cell. In hypocalcemia, the calcium ions outside the cell are few, and so they enter the cell slowly. These both affect the QT segment, either lengthening it or shortening it, and so prolongs or shortens the QT interval. The link of calcium ions with the duration of QT interval can be explained if we recall the action potential of ventricular muscle cell. There are 4 phases. In phase 0, the sodium enters into the cell and it causes depolarization, whereas in phase 3, the potassium leaves the cell and causes repolarization. The sodium influx and depolarization cause QRS complex, whereas the repolarization or efflux of potassium causes T wave. In between, there is the plateau formed by entry of calcium ions, and this plateau correspond to the ST segment between QRS and T wave. If there is hypercalcemia, there will be more ions outside the cell, and so more calcium are available, and so they will easily and quickly enter the ventricle muscle cell. If they enter quickly, the plateau will be for a shorter duration, and so the plateau, as it corresponds to the ST segment, the ST segment will also be shorter, and so the QT interval will be shorter as well. In case of hypocalcemia, there will be few calcium ions outside the ventricle muscle cell. They will enter slowly, the plateau will be longer, and so will be the QT interval.